Hello, Jill Moore. Can you hear me? Let's see. I can't hear you yet. This system is interesting. You can't hear me? Let's see. I can't hear you yet. Let's see. Do you have a Mac? Because if it's a Mac, you have to do a couple different things. If it's a PC, it's different. I think you can chat with me if you want to. It's a PC. Okay. I still hear good things about you, by the way. Everybody says the school government's got some amazing resources. Do you know? And I said, yes, I do. I already knew that. Is Amy Wall still with you guys or no? Yes, okay. Somebody asked me that question. I said, I think so. Let's see if I can help you. I still don't hear you, no. Somebody yesterday had audio issues. I don't know why. You're on Google Chrome? You're not on Internet Explorer. You need to be on Chrome or Firefox, ideally Chrome. You're on Chrome, okay. Do you want to log out and try again?
So it said my default. Can you hear me?
I can hear you now.
Okay, good. I just noticed that when I signed in, it said that my default is the integrated microphone, and apparently it doesn't allow me to switch to any other kind of headset. So I'll just have to talk to the computer and hope that we won't have heavy equipment noise outside my window today like I did yesterday.
Yeah, sometimes it's funny because I was thinking it probably was on your end. I was like looking at different things because because we had somebody yesterday who couldn't get audio, and it was definitely not the system. It was something that was interacting. I didn't know what it was, but okay.
Yeah, it doesn't give me an option of switching to a different mic, so I'll just have to use the computer, it looks like. So
now can you plug in like just regular earbuds? Does it let you do this?
I'm sorry for interrupting you. That's what I was using when I signed in the first time. I had regular earbuds, and then I tried the machine, and then I tried the other. That doesn't sound good. Anyway,
it's funny because my work computer will not let me I can't use these earbuds. So I've decided computers are fickle.
I agree. So now my question is if I can share slides for.
Yes, I'll work you through that.
My group. Oh.
So if you click share, you see share at the bottom. There's like there's a like it looks like a computer screen with a thing. If you hit
I see that. Yep. Okay. Share your screen. And so
where are your slides? Put your slides in reading view first. Do you have your slides on your desktop?
what do you mean reading view?
So yeah, it's weird. There's a thing that looks like a book. And it actually, if you could either look on the bottom, like where it has put in presentation mode in PowerPoint, and there's something called reading. Yeah, I've never seen that thing before. I've never used it.
I've never used it
in reading view, then click the screen share button at the bottom.
Got that.
And then if you now look at the top, it has a place that says application window.
Check.
Do you see that? Okay, click on application window, select your PowerPoint. Do you see your PowerPoint as an option? Okay, click on that and then put share. Okay, there you go. You figured it out.
Yeah. Okay. So now I cannot see you and I cannot see anything except the slide.
Yeah, that's I think that has to be, that's what I think is a disadvantage. I think I haven't figured out, you can minimize, like I'm going to minimize if you click. I think there is a way, let me think about it, because I know that yesterday people just didn't see themselves and it had to be, and I'm trying to think if there's a better way.
Okay.
Let me look.
So
I'm looking.
I did just minimize it and now I can see you and me again. But I can't see the slides at the same time.
Yeah, the slides are no longer on there.
Right. And I don't know if there's a way to do a split screen.
Well, they say there's a way to resize your PowerPoint to make it as small as you like, to keep an eye. So I'm trying to figure that out. I wasn't able to, let's see if I can figure it out with you. Let's see.
Okay.
I know how to get you presenting. I just haven't figured out. They say you can resize your PowerPoint window to make it as small or large as you would like.
Okay.
Once you're in there, and I haven't quite figured that out.
Okay. I'm now just flipping through slides just for practice. I'm still sharing, right? You can still see them?
Yeah, I can see. Mm-hmm.
Okay, good. All right. Yeah, because I'm driving the slides for everybody, so it would be nice to see something other than the slides. I don't care if I see myself.
Right. They can see you. I mean, we can see you and we can click on our slides and you're smaller at the bottom. It's just, I'm trying to, you know what? I'm going to ask Kim.
Okay.
Let me text Kim Dittman and see if she can help.
Okay.
Because this, I'm excited that I figured out some, but that one I hadn't figured out.
There's something here called display settings.
Oh, maybe I know.
I don't know if I want to mess with that because it's an application restart required. I think I'm going to not mess with that.
Can you come to I'm going to ask him to come in here, legislative.
Okay.
Update session and help us figure out how the presenter can show slides, can show and see them, show slides.
It really, for me, it's seeing the other speakers because I'm
see the other speakers. Yeah. Mm-hmm. No, okay. I'm glad you came on early.
Yeah, I briefly attended a 9 o'clock session and they spent the first 20 minutes working on tech. And I said, okay, I'm going to leave this session and get in mine.
Yeah. No, I'm not a big fan of that either. Let me see, Kim or Milton. I'll see if she'll respond.
Okay.
So, and I'm like looking at my thing. I'm trying to think if I have anything to help. I guess I could try to share a slide. Let me see if I can figure out. Well, I don't want to be doing it at the same time as you. So there's no way to resize that so that you can.
Not that
it doesn't let you.
I can't figure it out. Now that doesn't mean it can't be done.
No, I know.
That just means I can't figure it out.
Well, I don't think, I think it's a lot to expect speakers. You know, a lot of times, you know, the organizers have all this stuff. I've been really, I like had a mini panic attack like 2 nights ago because I thought this is a lot to expect speakers to figure out.
Yeah.
Hence the thing you just told me they spent 20 minutes. That's my fear.
Yeah.
That I don't want to do that. So,
And so I also just made a mistake and I clicked on something and now I can't figure out how to stop my screen share. So I'm just having all kinds of problems.
it's not sharing anymore. I don't see it.
Oh, so I stopped it.
Yeah, you stopped it. I don't see. And I'm going to see because I'm going to show you. Let's see.
Okay. So I stopped
I'm going
it.
to
And
show
so
you
now
what it looks like.
So if I want to share again, I go here.
So I can't see. So I'm sharing. Can you see my slides?
You know what? My slides are no longer showing in the sharing window.
Can you see my slides or no?
Yes, I can.
All right. What I'm trying to do is figure out, so you just see your slides when you're doing stuff. Like you can't see a thing. I can't see a thing.
That's what I was seeing. However, just a minute ago, I clicked on something, they went away. Here. And now I can't seem to share my screen again. Let me try.
All right. Well, I stopped being in there.
So I've got my slides back into reading view. And now I'm clicking on the little computer monitor. I'm clicking on application window and it does not, it doesn't show the slides.
Oh, are your slides on your desktop still?
Yes. It's exactly what I did before, only now it doesn't show. Under application window, it doesn't show.
It doesn't show.
Does not show.
Well, can you slide, or is it the only thing that's in there? Meaning sometimes it might be there and maybe it moved?
The only thing that'll let me share is my entire screen.
That's weird. So my suggestion would be to log in and out again.
Yep, I agree. Bye.
Okay. Hello, welcome.
Hey, it's Pam Perry with Carolina Complete Health.
Hi, so you can hear me, good. So that's a good start. I'm Jerry Matson.
Hey, Jerry.
Hey, I'm with Edmonton Children's Health Section. I'm just, I know you've been probably talking more with Lindsay, who's with nursing. I'm one of these nerds who just likes to get here early because tech is
Yeah, so what time does this session actually start?
10:15 and
Hi.
Hi. Lindsay, can you hear me?
Yes, I can.
I'm so glad to see you because you have the backup slides, right?
Yes, I do. And I've got them pulled up on my screen, ready to go.
Okay, so I've been having some screen sharing issues. I was sharing my slides and then I clicked on something rogue, they disappeared, and now I can't share them anymore. And I don't know what's up with that. I was wondering, however, a solution could be if you would be willing to advance the slides for all of us. And I apologize for having to ask.
That's okay.
And Jill, that allows you to see everybody too, technically, meaning that gets over, because we weren't sure how to get you.
That was the problem I was trying to solve when I clicked on something rogue. But now when I go to screen share and click on the application window, it doesn't show my slides, even though they're open on my desktop. So I have no idea what I did. I broke it.
Okay.
I broke my own interface at least.
That's why I had everyone send me a backup.
Okay.
in case
Okay.
something crazy happened. And I will, full disclosure, the last session that I moderated, something weird happened where I was getting an audio feed actually from another section. I have no idea how that happened. It stopped after about 10 minutes. So
That can
hopefully we don't.
happen. Yeah, sometimes that happens. Even sometimes the questions or the chat, not this one, but I've been on others where that can happen.
So it stopped after about 10 minutes and it shouldn't affect you that much. It seemed like it was mostly just affecting me as an organizer. So that, after I do introductions, it should not affect you if it happens again. But
Okay. So I'm going to notify Virginia and Kirsten because I don't know if they'll be on at the very beginning or not.
Kristen's here. I saw Kristen on.
Kirsten Laludis. Oh, there she is. Hey,
There she is.
Kirsten. Kirsten, we've been having some issues with me sharing the slides, so Lindsay is going to drive the slides. So, but that doesn't make a difference for you. You just say next slide when you're ready.
Okay, that sounds great.
And Lindsay, Peg doesn't have any slides, so after the initial disclosure slides, I think it's just her.
yeah. So what I'll do is I will put up the disclosure at the beginning, and I will do all of your introductions. That way people can kind of read it and listen to your introduction. And then I'll remove the screen so that she can present, and then I'll put it back up for the legal section.
Sounds perfect. Yeah, and then we'll just immediately go to the start of Kirsten's slides because she's the first speaker.
Okay.
On the legal update section.
Right.
Thank you.
You're welcome.
So glad we have the backup plan. I have no idea what happened. I was sharing the slides and then they disappeared, and they're still on my computer.
It's okay. It's all
I
right.
hope that doesn't happen to you.
We're gonna work it out. It's gonna be okay.
And Jill, maybe while you're here, are you going to use the feature where you have your slides and your video up? I'm ready to do either. I just want to be consistent with you in Virginia.
I did. What would I do to have slides and video on at the same time?
So there's nothing that you need to do. So anyone who is participating can share their screen and their audio and their screen share. So I'll put up the screen share, and then your face will also, if you have your camera turned on, will also show.
Okay.
That's all you need to do in order to maximize the video. And I'll put instructions over on the chat. People just need to double click like the little box that says slide so that they can see it larger.
Okay.
And I will turn off my video for me so that people don't get confused. It'll just be your slide.
And I'll turn mine off when I'm not speaking. So yeah, practice that. Yeah, good. It comes and goes as it should. But when I'm speaking, Kirsten, I am going to have mine on when I'm speaking.
Okay, sounds great.
I even sort of straightened up my bookshelves in my office today, but don't look too closely. There's all kinds of random things jammed in to keep it from looking like books falling over.
I was joking with the nursing section earlier. This table behind me usually has all kinds of stuff on it, and now it's just sitting on the floor.
I've been mostly working at home, but my daughter, who goes to UNC and lives here in Chapel Hill, had a pipe burst at her apartment. And so she's been back at our house, and we've had all three of us working and on Zoom. And I thought I better go into the office just to make sure I've got a strong connection.
Wow.
All right, I'm going to shut up and mute my mic now. Talk to y'all soon. Okay. I'm going to go off camera for now too.
Yeah. Same.
Good morning, Virginia.
Hey, good morning.
I think we've got Lindsay, Jerry, and Jill on the screen. They have stepped away just for a moment.
Okay, awesome.
Good morning, Virginia.
Good morning. And I struggled to put something behind me that would be okay.
This is a
But I'm-
common theme.
Oh my gosh. Can you guys see me? Oh my God, I did it. I'm so excited. Thank you, Lindsay.
You got it. You got it. Virginia, so Jill was saying, I don't know if she had texted you or notified you. Jill was saying that she was having some issues sharing her screen. I'll be advancing the slides for you. I have a backup.
Okay.
Of your slides. So you'll just need to notify me just say next or something like that so I know to push the button.
Okay, perfect. It's like Jill went to her office.
Yes, I'm at the old office today. Good morning, everyone.
I should have done that. Good morning.
I don't know. I like the artwork behind you. I can't quite tell what it is, but it looks very cool.
It is from Taiwan. A friend of mine brought it back from Taiwan.
Neat.
It's basically the only place in my house where you don't see just like stuff behind me. So I'm sitting at the kitchen table.
I just realized my husband's hat is about to fall off. All right. You know, I have so many cool cartoons, political cartoons about our days in trying to take things smoke-free and increasing the cigarette tax, but I could never figure out how to get my computer. I'd have to move everything in my office. So, but there's one that's hilarious. It's Sir Walter Raleigh wearing a Nicoderm patch when we were able to get the smoke-free law passed. And then there's another one that is the state of North Carolina that looks like an ashtray, and there's someone snuffing a cigarette out. I mean, it's such a long time ago, but they're still perfect. Cartoons, they'll be on my wall till the day I die. I have entirely too many pieces of paper. And where's my phone? Turn it off.
I hear you on the too many pieces of paper. Because I've moved to
It's
this
the
tiny
lawyer.
table and I don't have room for all of my paper.
And it's a lawyer's nightmare. What can we say? All right, so I need to set my timer so that I don't go over, because I think I'm so entertaining.
From the chat, it looks like we might have other people entering the session. I'm not sure about that, but just so that you all know, I'm planning to, I'm going to keep my camera on while Lindsay does introductions, but then I'm going to disappear while others are talking, and I'll come back on camera if I have to. I will.
I like that approach. I'm gonna
Yeah, I
do
was
it
going to
too.
say, save it from ourselves.
So I will introduce our sponsor, and then we'll put up the disclosure side, and I'll introduce our speakers. And then after that, Peg can take it away.
Great. I'm going to go on mute now as well. So talk to you all in a bit.
Thanks, Jill. You know, this was not as scary as I thought it was going to be.
Good morning, everyone. It is 10:15, so we will get started. My name is Lindsay Novacek. I am the chair of the nursing section of the North Carolina Public Health Association. Jerry Matson is also here as the chair of the Women's and Children's Health section of the North Carolina Public Health Association, and we are honored to co-host the legal and legislative update this year. We do have a sponsor, Pamela Perry from Carolina Complete Health. Pamela, are you with us? Maybe she will join a little bit later. I'm not seeing anything in the chat box or anything like that. It's okay. Please bear with us. We may be experiencing technical difficulties, so just bear with us, okay? Can you see the slides? Well,
We could.
okay. All right, let me turn off my video. Okay. All right, I may not be able to monitor the chat box since I am sharing the slides today. So please notify if there are any issues. Can you see the slides now? I'm going to need one of the other organizers to let me know.
Yes, we can see the slides. You might want to put it in reading view. There you go. Perfect. This is Jerry Matson. I can hear and I can monitor the chat box. And for those of you who want to see the slides more, go ahead and double click on the slides and that'll bring that up so it's bigger and everyone else's videos on the bottom.
Thank you. All right. I would like to introduce our speakers today. We have 4. Firstly, Peg O'Connell is the chair of Care for Carolina, a coalition of 67 organizations committed to finding a North Carolina solution for closing the health insurance coverage gap. She is also the chair of the NCPHA Advocacy Committee. She recently retired as senior advisor for government and public affairs with the Raleigh consulting firm of Fuquay Solutions. She has over 25 years of experience in legislative, public health, regulatory and governmental affairs, healthcare, media, and grassroots advocacy at the state and federal levels, and has been active in North Carolina working to improve the public health by reducing smoking and obesity. Kirsten Lulaudis is a policy and legal specialist in the Office of Regulatory and Legal Affairs for the Division of Public Health and the North Carolina Department of Health and Human Services. Kirsten currently works primarily on public health rulemaking and data sharing. She also serves as the administrator of the division's Institutional Review Board. Kirsten received her BA from Earlham College, her JD from the University of North Carolina School of Law, and her MPH in Health Policy Management from the University of North Carolina Gilling School of Global Public Health. Virginia Niehaus serves as Director of Regulatory and Legal Affairs for the Division of Public Health in the North Carolina Department of Health and Human Services. In this role, she works on public health policy development through the legislation and rulemaking and consults on implementation and enforcement of public health statutes and rules. She serves as rulemaking coordinator to the North Carolina Commission for Public Health and is a member of the North Carolina Local Health Department Accreditation Board. Virginia received her BA from Duke University, her JD from the University of North Carolina School of Law, and her MPH in Health Policy and Management from the University of North Carolina Gilling School of Public Health. Jill Moore joined the Institute of Government in 1997, following a one-year judicial clerkship with the Honorable Willis P. Witchard, Supreme Court of North Carolina. At the School of Government, Moore focuses on selected issues in public health law, including North Carolina communicable disease law, health information, privacy, and adolescent health. She hosts the annual legal conference for North Carolina local health directors and maintains a website devoted to NC public health law. Moore earned a BSPH, MPH, and JD from the University of North Carolina at Chapel Hill. Please welcome our speakers, and Peg when you are ready.
Very good. Well, Lindsay, I have to just say that you left out that I graduated the Ohio State University College of Law. I'm sure that was simply an oversight just because everybody else is a Carolina graduate. But I have to tell you, it's very intimidating being here with real lawyers because I haven't been a real lawyer in a long time. So I was asked to give a brief update about legislative events over the past year, but this has been such a weird year, actually the weird last couple of years, that in all honesty, I wasn't exactly sure where to begin. So I figured I would start at the beginning. I'd tell you a little bit about the Advocacy Committee and what we do and how we make our advocacy agenda, and then move you through what's gone on the last couple of years. So the Advocacy Committee is a standing committee of the NCPHA Governing Council, and I have been the chair for the last 10 years, which may tell you how long I actually, how old I actually am. Each section, including nursing and women and children's health, has a representative that sits on the Advocacy Committee. Several months before a new session begins, whether it's the long session in the odd numbered years or the short session in the even numbered years, we send out a broad request to members of NCPHA for ideas and suggestions about what we should include on our policy agenda. And then the section advocacy committee representatives also go back to their sections during your section meetings and talk up what are the things that we think as nurses, women and children's health professionals, epidemiologists, environmental health professionals that need to be addressed from a policy perspective. And then that is all brought back. There's a broad dissemination of an application process just so we can keep things kind of moving in at least a forward direction. And then, so when all that comes back, the Advocacy Committee goes through all the applications. Some years we have 5, some years we have 25. We go through that and start to glean if there are common themes among the sections or broad overarching public health goals. We also ask our partner organizations. Many of you know the North Carolina Alliance for Health. I chair Care for Carolina. We work with the Heart Disease and Stroke Prevention Task Force. And so the A4C to get policy issues that they're working on that they may want us to lend a shoulder to the wheel. 2 years ago, we worked with a group that was trying to prevent the privatization of liquor sales because of the public health implications of easier access to alcohol. So we put them through our process, and the committee compiles this list. We look to see, are these things that are being sent up from the sections and in from our partners, are they consistent with the NCPHA message and mission? And then we go through and sort of give them a priority. We have 3 levels. If things make the first couple of cuts, one is support, which is our strongest. That means we will lead on the issue. The second is endorse, which means that someone else, perhaps the North Carolina Alliance for Health or Care for Carolina, is leading on an issue, and we are lending our name and credibility and perhaps our grassroots to the issue. And then the third place where we find ourselves a lot is when issues aren't ripe for consideration as a policy agenda item, we continue to gather information. So we also endorse broader policy statements. So it doesn't necessarily have to be the law, section 5 needs to be changed, such and such. We will go through and look at broad policy statements that give us a lot of room to maneuver as things come fast and furious in the legislative process. A few years ago, this was exceptionally important in working with the environmental health section when we were seeing so much what was called regulatory reform, which in my world was, in my personal view, was deregulate the hell out of everything. So by creating those broader policy statements, we're able to kind of pivot when we need to. I think we will be working very soon with Jerry to put together a broad policy statement on family-friendly workplaces and workplace regulations that help the health of moms and kids moving forward. That, again, will give us a chance to maneuver as the legislature comes back into session. So what the Advocacy Committee does is they finalize these recommendations, and then we send them to the Governing Council, which is the large governing body for NCPHA. Sometimes they just say, yay, that's a great idea. Other times they say, you know what, we're not too sure about this. Why don't we take this out? Can we put this in? And then anyway, there's a back and forth process when finally the Governing Council will approve the policy statements and the advocacy agenda. And then we push it out broadly to legislators, to our partners, to our members, to the media, in order to let them know where NCPHA stands. I do want to tell you one thing, and then I'll move on to some more substantive issues. The policy agenda for NCPHA is never frozen in time. We know that as public health professionals, we know that, especially this year, that things can change dramatically. And so we are constantly reviewing and considering support for new issues. We do a lot of work with APHA to sign on to national focused issues or national focused pieces of legislation. So that is a constantly moving thing through the Advocacy Committee, then up to Governing Council. And sometimes Governing Council will just say, you know, this is too important. We haven't got time to wait. Let's sign on right now. As far as I'm concerned, if APHA sends it down, it is pretty solid as far as the science and the policy behind this. So that's our process. So, and I want you all to be aware, because pretty soon we will be sending out this broad communication once our new leadership gets in place, and we will be soliciting information from all of you, especially nurses and the nursing session and women and children's health, because so many things are changing where you all are the sort of the center of the universe. So in the chat box, I think Lindsay can put up or will put up the link on the website, on the NCPHA Member Clicks website, to our 2019-2020 legislative agenda. So you can see that. I will tell you, it was a beautifully crafted document. And then as things, thank you very much, Lindsay. As things developed, it all went right out the window. But, you know, I told Virginia and Kirsten that I would take 20 minutes because I live in a land of would'ves and could'ves and most likely should'ves. As they give their presentation, they're going to give you what actually has happened and how all that is being implemented. But so I get to kind of tell you a story. I'll start with the long session. That was the session that was in 2019. Again, that's when the legislature meets for a substantial period of time. In 2019, it was almost an entire year. Back in the old days, it could be 6 or 7 months. That's usually when the major piece of policy that's developed is the budget. But that's when you also see a variety of other big pieces of legislation be developed and start to move. We had some of the things from our policy agenda. Number 1 and 2 were $8 million for communicable disease prevention and staff in local health departments. Would have been a good idea. And then the second part was funding for school nurses at every school. Again, would have been a good idea. So with the help of Representative Donna White, and I will give full credit to Lynette on this, we were able to secure, so we had been asking, along with the health directors, for $8 million for this communicable disease program. The budget contained 6.5 million or 6.4.6 or something like that. And it was in the budget, and it was a big deal. We finally thought the budget is going to actually devote money to local public health, which has been a huge lift, especially over this last 10 years. And I'm not telling you guys anything you don't already know, the funding for public health over the last couple of decades has gone down, which is one of the reasons we find ourselves in a pickle right now. So, but we were all yay that about this. This was a big deal. But then the budget was vetoed. Governor Cooper had made two of his signature issues, one near and dear to my heart, Medicaid expansion or closing the coverage gap, depending on the language you like to use. And the budget contained nothing about that. There was a freestanding bill that was moving and it kind of got stalled. And then the governor did not feel there was sufficient money for education. So he vetoed the budget. For quite some time, the legislature was unable to override the veto of the budget. I think many of you have heard the term veto-proof majority. For the last 8 years, there was a veto-proof majority in the legislature, which meant even if a governor, whether it would be a Republican or Democrat, had vetoed a budget or any particular bill, the legislature could simply, they had enough votes lined up in one party to override. But they were not, this last 2 years, things changed slightly, and the legislature was not able to override the veto. So even though there was some excitement around 9/11 about that, so what happens is we had no state budget. So those of you who work for the state or work at the county level who depend on state money, you will know that fortunately, unlike the federal government, we don't close down when we don't get a new budget. The old budget just stays in place. So any of the new items, including funding for communicable disease, didn't happen. On the issue of Medicaid expansion, there was no further discussion. It kind of came to a big stalemate. Then we'll fast forward. So the legislature ends. There is no budget. Everybody go home around Thanksgiving. So then, but here comes 2020. Everybody's full of excitement and they think we can do this. We can do some good work. We can pass a budget. We can maybe talk about Medicaid expansion. We can maybe talk about school nurses. We can talk about some of these issues in a hopefully calmer, cooler, collected way. So the legislature in the even-numbered years is what's called the short session. The short session generally doesn't convene until around the 1st of May. Well, I don't know what you all were doing, but come about March 17th, which I remember because it's St. Patrick's Day and all the bars were closed, COVID struck North Carolina. And we went into a stay-at-home order by the governor, and everything sort of came to a halt. Our legislature didn't even know if it was going to be able to meet in order to try to get some of these issues moving. Well, as COVID dragged out, the economic devastation that followed was so great that suddenly the legislature that had been looking at almost $1 billion in surplus was looking at a giant hole in its revenue that they had planned to parcel out. That there was hope that during the short session they would actually come to some agreement on a budget. We all know that that is history. The legislature did convene. They did a lot of work around COVID, much like we're doing this now, distantly. The average age of the legislator is about my age, which puts almost every single one of them in a high-risk category simply because they're over 65 years old. So there was reticence on the part of some legislators to actually meet in person. So they did a lot of work. These COVID committees were formed, and they made recommendations on how to spend the money that was coming from the federal government for COVID relief. So they met a couple of times, made recommendations. We were hopeful that we would get some public health money from that, and money did go to the state. A lot of it is trickling down to the local departments, but not what we had expected. And again, if we had had investment in our communicable disease programs at the local level, we would be in perhaps a very different place in North Carolina. Although I have to say, compared to my friends in South Carolina, and even in Ohio, we're doing pretty well. So in the process of this whole COVID conversation, we were able to, and NCPHA, I'm the chair of Care for Carolina, but I sit on that, in that chair because I am part of NCPHA, which gives us a very big leadership role in what goes on the whole Medicaid expansion conversation. We were able to convince the House that they should put at least Medicaid expansion in for people who were diagnosed or tested for COVID. And we were like, yay, this, you know, in all honesty, this is the camel's nose under the tent. We might be able to get Medicaid expansion sort of by the back door. Well, the Senate would have none of it, and they pulled all that out. So you have a situation now where someone is tested for COVID, which the state will pay for, but then if they're diagnosed, they have no, if they're uninsured, they have no access to treatment or medication, or even an albuterol inhaler, which can cost $40. So it's, in some ways, it's kind of the worst of all possible worlds. So that's sort of what didn't happen. Some things did happen. So the legislature did convene. A number of public health advocates were reticent to go down to the General Assembly because there was not a mask requirement. And I don't have to tell you all how political mask wearing has become. Well, the General Assembly was sort of ground zero for that. But some things did happen. They met in summertime and moved some of the CARES Act money out. And then they met again in early September to sort of dispose of, I don't want to say dispatch the remaining parts of the CARES money. They had initially hoped, the legislature had initially hoped that they would be able to use that several billion dollars, millions of dollars, close to $1 billion, to plug holes in the state budget. But the federal government said, no, you've got to use it specifically for COVID-related things. So they did spend the money the best they could. And I wanted to give you all just an insight into a couple of things that happen that impact what we do as public health professionals, and especially the nursing section and the women and children's health. So $6 million in the new COVID relief package went to food banks. Almost $13 million went to the free and charitable clinics. So you won't expand Medicaid, but you will give money to the free and charitable clinics. And that's not taking anything away from them. Simply, I think if you would create a broader solution, you could get a better result. Almost $13 million to the community health centers, the FQHCs. There was $1 million to expand a prescription. So this is kind of funny. 20 million, it's not funny, it's sad, and I'm trying to be as upbeat as I can. $20 million to the division, the Department of Public Instruction for PPE in public schools. Very important, but not a dime for school nurses. A couple of interesting things when we were trying to advocate for some of the programs that we've been getting trickles of funding for years. Legislators were like, we have no money, don't even talk to me. But yet there were little bits and pieces that were sent to $1 million to Alamance County Schools for school nutrition, $500,000 to go to the northeast corner among 6 counties to share so that they could either put money in school nutrition or in transportation. There was one very good thing. $30 million came to a grant program to move out money into the broadband program. We have seen how there's the 2 North Carolinas are suffering. In areas like Raleigh, like I do, I turn on my computer, and even when I turn on my computer, my neighbors are all turning on their computers. It's a little tough. But when you live in Bertie County, it's really tough. And if you're relying on that for your education or your telehealth, it's tough. The one thing that I would say at least made some sense is the legislature gave schools flexibility so they can move money between line items. As many of you who work in government know that that's an absolute no-no. If somebody gives you transportation money, you either spend it on transportation or you lose it. This one sort of flip of the switch has allowed schools to move money back and forth between transportation, nutrition, educational needs. And so I think that's really good. For those of you who are involved in school nutrition, they've also have passed a temporary measure that will hold schools harmless for not having as many young people enrolled in their school nutrition program as they had initially estimated. And then I'll be very close to coming to an end so we can get on with the real lawyers. But a couple of other things that I think those of you who are interested in children's health, there was a huge expenditure of $440 million, which was nearly half what was left in the phase 3 of coronavirus relief coming to the state. That was called the extra credit. And what it did was it sent $335 to every state. So, which is a nice thing. If your kids are home all day, that would help feed your kids. The problem with it, from my perspective, is almost half the top 20% of income earners in the state. So you have people who are really in need, and then you just hand out checks to everybody. Does $335 really make a difference to somebody like me, where in a poor county or a poor family, it could make a great deal of difference to maybe get $1,000. So there were also a couple of things that affected childcare, and then I'll finish. So $35 million went to operational flexibility grants to help childcare centers stay open. You all remember when this all started, essential workers needed to go to work, whether they be grocery store clerks or public health professionals or police officers, and there was no place for them to take their children. So recognizing that, this grant program was set up to sort of support those programs that did stay open and did take all the extra precautions. There were also there was also $8 million allotted to give families that were trying to struggle with remote learning some funding that they might be able to get some kind of tools in order to facilitate the learning of their kids from home. And then one thing that sounded good, but has, I think, turned out to be a little troubling, and that was a bill that would give flexibility to daycare centers. There was a thought that the more daycare centers, the better, because of everything that's going on, and frontline workers need a place for their kids to go. But in doing that and expanding who could be a daycare center, they took off a lot of the safety restrictions that traditional daycare centers had to abide by, including some of this COVID-related specific rules and regulations. And so the verdict is still out on whether that was a good idea. I think it was well motivated, but it was also an attempt to deregulate. And oftentimes that can have unintended consequences. So, Lindsay, I know you heard that same report Governing Council the other day, but I am very pleased to take questions whenever the time comes. And I thank you very much for letting me talk to this very important two groups of public health professionals.
Thank you so much, Peg. We're always really honored to hear your voice and your expertise and your knowledge. And I'm very excited that you'll continue to be chair of the advocacy committee for the North Carolina Public Health Association. If anyone has questions for Peg or for our other speakers after they speak, please just drop them in the chat box and we will do our best to moderate and get those directed. I did just want to interject here. I know the legal team is going to be presenting next, but we do have a sponsor, Pamela Perry, that looks like she's joined us now. Pamela. Whenever you're ready, ma'am.
All right. Good morning. Turn my camera on. Hey, everybody. It's great to be here. Carolina Complete Health is one of the 5 health plans that will launch next July, July 2021, under the Medicaid Transformation Initiative. I know that many of you are well aware of that, that process and the fact that we now have a launch date, thanks to the session that just ended in July. And we're very much looking forward to serving the state. A little bit about Carolina Complete Health. We are a partnership between the North Carolina Medical Society, the North Carolina Community Health Center Association, representing the FQHCs across the state, and Centene Corporation. We will be operating in 3 of the Medicaid transformation regions. Of course, they don't match the public health regions or the LME-MCO regions or any other regions for that matter, but they're distinct regions set up for Medicaid transformation. We will be serving regions 3, 4, and 5. And just to oversimplify it, the 41 regions we will serve are clustered around the Charlotte area, Raleigh area, then Fayetteville and Wilmington. So that's 3, 4, and 5. If you have any questions, we have a booth. Still figuring out how to attend the booth and interact with folks, but feel free to send me a note directly if you're interested in getting more information. We really hope to be working with our public health partners around a lot of the initiatives that will continue under your purview, such as the CC4C, Pregnancy Medical Home, OB Case Management initiatives, and then any other initiatives or capabilities that you'd like to see expanded or included in your contracts with Carolina Complete Health. So we're looking forward to those conversations if they need to, be restarted. But we're at the ready and doing a lot of work to implement and get ready for July. So thanks very much for the time today. Really happy to be here.
Thank you, Pamela. All right, I will present the screen for our legal speakers. Just give me a second. Were you able to see my screen? Okay, well, I'm going to put it back up whenever you're ready, Kirsten.
All right, I am ready. You can jump on in. And folks may have seen these instructions earlier, but if your slide screen looks small and you would like to see the slides in a bigger format and my face in a smaller format, you can double click the video of the slides. All right. Well, good morning. I hope everyone's day is off to a good start. I'm really glad to be with you for this session, during which I'll be presenting on North Carolina's minor consent law and a handful of selected issues, including minor opt-out from NC Health Connects and minor consent to certain vaccinations. We'll jump to the next slide. Thank you. We can jump on to the next one. Thank you so much. So as many of you may already know, North Carolina has a statute that gives minors the legal authority to consent to certain medical health services. Minors under North Carolina law are individuals who are younger than 18 and who are unmarried or who have not been emancipated by the North Carolina court system. And in most circumstances, and I say most because beyond the minor consent law that we are talking about today, there are some other exceptions. But in most circumstances, a parent or guardian has to give consent in order for a minor to receive certain medical health services. However, under General Statute 90-21.5, North Carolina's minor consent law, minors can consent on their own without requiring their parent or guardian's knowledge or permission to medical health services for the prevention, diagnosis, or treatment of the following: sexually transmitted diseases or other reportable communicable diseases, pregnancy, but note that minors cannot receive abortions or medical sterilization services under this statute, what the statute calls emotional disturbance, And again, here, note that there are some limitations. For example, minors cannot consent to admission to a 24-hour facility except in emergency situations, and for the abuse of controlled substances or alcohol. And this has the same limitations I just mentioned. Minors cannot consent to admission to 24-hour facilities for alcohol or controlled substance abuse services except in emergencies. It is important to note that this statute gives minors the legal authority to consent to certain medical health services. However, in addition to having legal authority, the minor also needs to have decisional capacity. And decisional capacity is sometimes also referred to as competence. A person has decisional capacity, is able to understand things like her health condition, the treatment being offered for that condition, treatment alternatives that may exist, and the risks and benefits associated with those various treatment options. So in Carolina, there is not an age cutoff as whether a minor has decisional capacity. It's really established on a case-by-case basis. So the law starts from a place of assuming that minors lack decisional capacity unless demonstrated otherwise. Therefore, when a minor is seeking to receive medical health services that are covered under GS 90-21.5 on her own consent, that minor may have the legal authority needed, but it's up to the provider to determine that the minor also has the requisite decisional capacity to be able to consent to and receive those services. Next slide, please. The minor consent law comes into place in numerous settings, including with the North Carolina Health Information Exchange System, which is called NC Health Connects. NC Health Connects is operated by the North Carolina Health Information Exchange Authority, or the HIEA, and resides within the North Carolina Department of Information Technology. NC Health Connects is a standardized electronic system through which providers can share important patient health information. And one of the goals of NC Health Connects is to break down information silos between healthcare providers and to therefore be able to provide better patient care. So an example of how NC Health Connects could work would be a patient who goes to a primary care provider, but then presents at an emergency department that's part of a different health system. So if the primary care provider and the emergency department provider are both connected to NC Health Connects, then the provider and the ED can access health information about the patient that's already been shared in NC Health Connects by her primary care provider and any other providers that she might have seen who are also connected to NC Health Connects. So under North Carolina General Statute 90-414.4, most providers, including local health departments, are required to connect to NC Health Connects so that they can begin sending in patient health information through the system. The law also provides individuals with the right to opt out of having their patient health information shared through NC Health Connects. An adult opt-out form was established earlier on, and it allows adults to opt out of having any of their health information shared in NC Health Connects. Minors can use that form to have their information kept from being visible in NC Health Connects, but they have to have their parent or guardian sign that opt-out form for them. So it was determined that there needed to be a process and a separate form that a minor could use when she decides that she doesn't want her health information to be shared in NC Health Connects, in those limited situations where the minor is receiving, on her own consent, the medical health services that are described in General Statute 90-21.5. Next slide, please. So the HIEA, which again operates North Carolina Health Connects, has developed a minor opt-out form for use by local health departments. And I know it's probably very small on your screens, but I have screenshots here of what we expect to be the final version of that form. It has also already been translated into Spanish. And so the way this will work is that a minor will present to a provider seeking the medical health services described in General Statute 90-21.5 and seeking to receive those services on her own consent. The minor will sign this minor opt-out form, which will be kept by the provider, and the provider will then send the form to the HIEA. So the provider must send this form to the HIEA within 2 days of the minor child's visit so that the HIEA can find the form in its system and ensure that the minor's records pertaining to those services the minor just received are stored in a separate part of the North Carolina Health Connects system and are not made visible to other providers accessing NC Health Connects. A pilot program for the minor opt-out has been in the works for several months now, and several local health departments have been part of that pilot. And my understanding is that the HIEA is preparing to roll out trainings on the minor opt-out process more broadly too. And again, before we transition to the next topic, I just want to reiterate that minors can only opt out of having their information shared in NC Health Connects if that information is about medical health services that the minor received that are covered by General Statute 90-21.5. So again, that would be prevention, diagnosis, or treatment for sexually transmitted diseases or other reportable communicable diseases, pregnancy with some limitations, and emotional disturbance or abuse of controlled substances or alcohol, again, with some limitations. Next slide, please. And this brings me to my final topic, minor consent and vaccination. So as I have highlighted here on this slide with the bolded terms, General Statute 90-21.5 allows minors to consent to medical health services for prevention, diagnosis, or treatment of several things, including reportable communicable diseases. In North Carolina, by way of statute, the North Carolina Commission for Public Health is given authority to establish the list of diseases and conditions that are reportable in this state. And that list is codified in rule as part of the North Carolina Administrative Code. Virginia is going to speak more about the rulemaking process and some of the recent changes to North Carolina's communicable disease reporting rule in just a moment, but I want to touch just briefly on how this rule intersects with minor consent. As some of you may know, varicella, the virus that causes chickenpox, was previously not on the list of diseases and conditions that must be reported in North Carolina. And this meant that in the past, a minor could not, for example, get the varicella vaccine on her own consent. However, the rule on reportable diseases and conditions has been amended this past year, and as of July 2020, varicella is reportable. So this means that as of July 2020, a minor can consent to receive the varicella vaccine. Similarly, COVID-19, which is a novel coronavirus, was made reportable in February of this year, and that means that when a vaccine eventually becomes available, minors can consent on their own and without parental permission to receiving that vaccine. In the meantime, it also means that minors can consent to medical health services for the diagnosis and treatment of COVID-19 too. So this concludes my portion of this morning's presentation, and I look forward to answering any questions you may have at the end. And for now, I will turn things over to Virginia Niehaus.
Hey, good morning. Thanks, Kirsten, and thanks to also for the great presentations. I have the privilege of providing a legal update around public health rules and executive orders this morning. And as you might imagine, there has been a bit of activity in this space in the past months, much of it in response to the COVID-19 pandemic. Next slide, please. Thank you. I'm going to first start with some updates to the communicable disease administrative rules. But before I do that, I just wanted to sort of briefly level set for those who may be less familiar with our state administrative rulemaking process. So generally speaking, the legislature sets broad policy through statute, and Peg was talking a little bit about that earlier, and grants agencies authority to adopt implementing rules within their areas of expertise. And for the state of North Carolina, the North Carolina Commission for Public Health is the public health rulemaking body authorized and directed by the legislature to adopt rules to protect and promote the public health and implement the Division of Public Health programs. The commission meets quarterly or more often as needed and has met more often during the public health pandemic to take up rulemaking efforts. There is an extensive process for rulemaking, which is set out in statute under the North Carolina Administrative Procedure Act, which is General Statute Chapter 150B, Article 2A, which sets out processes for emergency, temporary, and permanent rulemaking. I'm not going to get too deep into the weeds on that this morning, but just to say that there's abbreviated notice and comment periods for emergency and temporary rulemaking, which allows those rules to go into effect more quickly. But the rules are time limited and later need to be revisited under the permanent rulemaking process. I just wanted to set out that distinction because the Commission for Public Health has done some emergency and temporary rulemaking during the pandemic. Public health rules are found largely in two main areas of the North Carolina Administrative Code. Title 10A, chapters 39 through 62 of the code contains the majority of them, including the communicable disease rules that we're going to talk about today. Environmental health rules, just for awareness, are in Title 10A, subchapter 18A. And on this slide, I've put a link to the Commission's website, a link to the Administrative Procedure Act, and also a link to the North Carolina Administrative Code for easy access. Next slide, please. So as most of my rulemaking updates pertain to communicable disease reporting, I just wanted to also briefly share the communicable disease reporting requirements, of which all of you are probably aware, but just to do a little level setting. So every state has laws that require certain individuals to report certain communicable diseases to public health officials, and these are known as reportable diseases. In North Carolina, the reporting statutes are found in General Statute Chapter 130A, Article 6. This sets out the individuals, including physicians and laboratories, school principals, childcare operators, who are required to report communicable diseases and conditions that are declared reportable under the Commission's rule, which Kirsten mentioned is 10A NCAC 41A 0101. That's where our reportable diseases and conditions list is found. I also briefly wanted to mention that the state health director has some separate authority granted to her under General Statute 130A-141.1 that allows her to issue a temporary order requiring healthcare providers to report information that may indicate the existence of a communicable disease or condition that's outside of the Commission rules. And it sort of allows public health to adapt quickly in the cases of emerging diseases or conditions to receive the information needed for public health surveillance and investigation. These orders are good for up to 90 days, and the Commission has the authority to continue them by rulemaking, which they have done in several cases over the summer. Next slide. Thank you. So now I'm going to talk a little bit about the reporting of COVID-19. In this case, the state health director, Dr. Betsy Tilson, has issued a couple of these state health director temporary orders to report in early 2020, February and March, around the reporting of novel coronavirus infections and deaths. This was then followed up by some emergency and temporary rulemaking by the Commission for Public Health. And I know that these are very small on your screen, but on the bottom are the two state health director orders, followed by the temporary rule, because we're now under temporary rulemaking procedures as it appears in the code. This will soon be followed up by the Commission with some permanent rulemaking. There are three things that I just wanted to quickly note about this administrative rule. So the first is that the term in the rule is that was used as novel coronavirus. So novel coronavirus infections and infections causing death are reportable rather than COVID-19. This was done so that the rule would capture COVID-19, a new emerging type of coronavirus, but also to be flexible enough to capture potential future emerging coronaviruses, although we all hope that does not happen, but just thinking back to MERS and SARS. The second thing is that the rule sets out reporting timeframes. So COVID-19 infections are reportable immediately, and deaths are reportable within 24 hours. And then finally, being added to this reportable diseases and conditions list does have implications for other statutes, such as the minor consent law that Kirsten was talking about. And I believe Jill is later on going to be talking about a communicable disease confidentiality statute, General Statute 130A 143. Next slide, please. I also wanted to note a couple of other COVID-19 related communicable disease rulemaking actions that happened over the summer. So first, the state health director issued yet another temporary order in July, this time around the reporting of COVID-19 diagnostic test results. This was based in her statutory authority, but it also filled a legislative requirement that was contained in one of the General Assembly's COVID relief bills that Peg was talking about earlier, requiring the department to collect and publish certain COVID-19 testing information. Following that state health director order, the Commission engaged in emergency and temporary rulemaking to adopt a brand new rule around COVID-19 diagnostic test results. This is 10A NCAC 41A 0107. The site is up there on the screen for you. This set out certain requirements reporting of both positive and negative COVID-19 diagnostic test results. And it also added some new healthcare providers as reporters. So under the rule, laboratories with limited exceptions are to report positive and negative diagnostic test results for COVID-19 using electronic laboratory reporting. It also requires healthcare providers to report healthcare providers more than just physicians, so also dentists and pharmacists and nurses and other categories of healthcare professionals as defined in the rule to report positive results for COVID-19 diagnostic test results by fax and aggregate positive and negative results through an online survey. And the hope really is to move a lot of the COVID-19 reporting to an automated format, because it's been challenging to keep up with the number of fax reports coming in, both at the state and at the local level. I did want to note that the requirement for healthcare providers to report is considered met under this rule if the laboratory that receives the specimen for testing will report, to try to avoid and cut down on duplicate reporting. I also wanted to sort of mention a nuance that if healthcare providers are performing testing on site, so they have an on-site facility that's certified by CLIA or under a CLIA certificate of waiver, they are considered a laboratory for purposes of this rule and expected to comply with the laboratory reporting requirements for positive and negative reporting through electronic laboratory reporting. For labs that are not, who don't have ELR technology sort of built in now, the state has set up an automation process that's detailed in the rule and in some other guidance that was posted to help laboratories come on board to electronic laboratory reporting. Positives are reportable immediately, and this is in alignment with our 41A 101 reporting rule, and negatives are within 24 hours. This rule was effective September 25th, and the temporary rule is actually out for notice and comment right now until October 16th, and there's more information about that on the Commission's website. The other communicable disease COVID-related rulemaking effort I wanted to mention is related to a petition for rulemaking that the Commission for Public Health received from the North Carolina Board of Funeral Service in June. The board requested that the Commission amend Rule 10A NCAC 41A 0212 regarding the handling and transportation of bodies for communicable disease control to require that notifications be provided to persons handling the bodies of individuals who have died and are known to be infected with COVID-19, the proper precautions to be followed. The Commission considered and granted that rulemaking petition over the summer, and on September 15th took emergency action and temporary action on the amendment to this rule, which adds a notification requirement when a person dies and is known to be infected with COVID-19. This applies to physicians, physician assistants, nurse practitioners, attending to the person, as well as to medical examiners if the body is under the ME jurisdiction. It sets out the precautions to be followed in alignment with CDC guidance, and it also makes some other technical updates to enable notifications and ensure appropriate handling and transportations of bodies. This rule was also effective September 25th and is also open for public comment right now. Next slide. Before leaving rulemaking, I also wanted to touch on one permanent communicable disease rule change that recently went into effect. 4 new things were added to the reportable conditions list effective July 1, 2020. Acute flaccid myelitis, babesiosis, varicella, which Kirsten kindly touched on earlier around the minor consent law, and also the reporting of interferon gamma ray release assay blood test results for the detection of latent tuberculosis. Next slide. Okay, I'm now going to just switch gears a little bit and talk about some of the COVID-19 executive orders that have come out over the summer, and this sort of like builds on some of the legislative action that that Peg was discussing earlier. But I do want to preface this with my expertise is not around emergency management law, but that NCDHS has been working very closely with the governor's office and the Department of Public Safety through the pandemic and around executive orders. In a minute, I'm going to transition to speaking about one executive order in particular, Executive Order 156, pertaining to immunizations and school health assessments. But I wanted to give a little additional context around the executive orders that have been issued related to COVID-19 first. So under the North Carolina Emergency Management Act, which is General Statute 166A, Article 1A, the governor as well as the legislature have the authority to declare a state of emergency if one is found to exist, including for a public health cause. The governor exercised this power in March to issue Executive Order 116 in order to coordinate a response to the COVID-19 pandemic. Since EO 116, there have been a number of other orders issued by the governor around the pandemic. I've listed some of those on the screen, focusing on the orders that have created and are subsequently beginning to ease in phases restrictions intended to slow the spread of COVID-19. But there at the bottom of that slide, you'll see a link to where all of the COVID-19 related executive orders can be found. Next slide. So this slide is a visual representation of the easing of restrictions under phases 2, 2.5, and 3. And I realize it's very small on the screen, but there's also a link there to where you can find this slide on DCHS's website as well as other guidance. I'm not going to spend too much time here, although you can see how we're trending towards becoming more open, and in particular down in the right-hand corner, how some of the businesses that were previously closed under executive order are now being permitted to open with restrictions. And we can go ahead and go to the next slide. Okay, so now to focus back around the executive order for immunizations and school health assessments. And this slide is just to provide a little bit of background about what the state law is on this. So under General Statute 130A-152, every child present in the state is required to receive certain immunizations that are set out in statute and also an administrative rule that was adopted by the Commissioner for Public Health. The way that this requirement is often enforced is when a child enters the school system. So under state law, under 130A-155 and 130A-155.1, no child shall attend a school, child care facility, college, or university unless proof of immunization is presented. For schools and child care facilities, it's required to be presented on the first day of attendance, and for colleges and universities on the date of first registration. Under the statutes, there is a 30-day grace period for immunization information to be submitted, after which the student is required to be excluded until the immunizations are obtained. Separately, there's a similar requirement around school health assessments under General Statute 138-440. Each child who is presented for admission into kindergarten or a higher grade in public schools for the first time in North Carolina must show proof of a health assessment that's to be presented on the first day of attendance, also with a 30-day grace period for that as well, after which the student is to be excluded. And then there's tied to that also some reporting requirements around immunizations and health assessments to NCDHHS that typically fall in the fall of the year after the grace periods have expired. You'll go to the next slide. So the emergency conditions of the COVID-19 pandemic have made it difficult for many families to get immunizations timely. And so for that reason, the State Health Director, Dr. Telson, and the governor have issued a memo and an executive order to temporarily delay immunization and health assessment requirements to provide families with a few extra weeks to get these things done. I did want to note the State Health Director has this authority under rule, so under 10A NCAC 41A 0401 paragraph C to suspend required immunizations temporarily in emergency situations. So she exercised that authority through a memo that was issued in August. And in addition to that, Executive Order 156 supports the suspension and extends some additional deadlines. So under these actions, both the immunization requirements and the health assessment requirement were suspended until the end of September. And the 30-day grace period was set to run starting the end of last week. So October 1st of 2020 is when it began to run. So we are now within that 30-day grace period it's running. And the reporting requirements, the associated reporting requirements were extended until December 15th of 2020. One important thing that I wanted to note there at the bottom, my last bullet, so students who are not compliant following that 30-day grace period must be excluded from school, and that means both in-person and remote learning instruction. as failure to vaccinate leaves a child at risk for vaccine preventable diseases, and we'd like to encourage compliance with that. That wraps it up for me. Thanks so much, and I'm going to turn this over to Jill Marsh, who's going to talk about confidentiality and information sharing. Jill, you may be on mute.
I just made the old person mistake that I was afraid I was going to make. Thank you, Virginia, for saving me from myself, as you so often do. Good morning, everyone. I'm glad to be with you and hope that you can hear me now. I have two completely different topics under the general umbrella of confidentiality that I want to talk to you about today, so I've subdivided it a little. If we'll go to the next slide, I'll tell you about the first one. I also wanted to just take the opportunity to share this amazing photo. If you haven't seen it, the UNC School of Medicine has a lab where they have an electron microscope, and they were able to produce this imagery of the SARS-CoV-2 virus on epithelial bronchial cells. I think I said that backward. I think it's bronchial epithelial. I'll let the healthcare providers correct me on that, but they were able to do that and colorize it, and so you can get this incredible picture that I wanted to share. And my first topic about confidentiality is related to COVID-19. There have been a lot of questions about disclosure of information about COVID-19 since the pandemic first became very relevant and salient in North Carolina back in the spring. People have had questions about when can information be disclosed, how much information can be disclosed, who can disclose it, to whom may they disclose it, do they need a release? What does it mean for information to be individually identifiable? What if it's just numbers, etc.? Lots and lots of questions coming up. And there are a lot of laws about confidentiality of health information, as I'm sure you're all aware. So during this part of today's session, I'm going to be speaking about two of the confidentiality laws that apply to this issue. I'm going to talk a little bit about HIPAA because it's unavoidable, but I'm going to focus in on a state law that is specific to information about reportable communicable diseases. A minute ago, Virginia mentioned that whether a disease is on the reportable list has implications for other laws as well, and one of them is confidentiality. So let's look at that first. That's on the next slide, please. GS 138-143 is the law that we look to for answers to many questions about confidentiality in COVID. We also know this as the North Carolina Communicable Disease Confidentiality Law, for those of you who don't speak in letters and numbers. This law says that information or records that identify an individual who has or may have a reportable communicable disease are strictly confidential and not a public record. And as Virginia has explained, COVID-19 is a reportable communicable disease, so it's covered by this law. This law has its own rules about when you can disclose the information that is covered by it. And generally speaking, this law is stricter than HIPAA. So those of you who work with HIPAA, which is probably everyone, you may recall that HIPAA partially preempts state laws, but it does not preempt state laws that are stricter than HIPAA. There are several provisions in HIPAA that allow disclosures for public health purposes to be made in accordance with state laws. So the details of that get a little hairy, but the bottom line is that when both HIPAA and this state law apply to information, which is often the case, especially when the health department is the one that has the communicable disease information, this law is often the stricter one, and therefore it's the one that we tend to go to first to determine whether a particular disclosure of information that folks are asking about is permitted. On the other hand, I don't want to completely disregard HIPAA. When it does apply, it can be a little prescriptive in whether and how you can make a disclosure, and we'll talk about that in a moment when we discuss data. But often when you ask a confidentiality question about COVID or another reportable disease, you'll hear us going to this one first, and that's why. This law specifies 11 circumstances in which information that identifies a person who has or may have a reportable communicable disease can be released. And those include with the written consent of the individual or the individual's personal representative if they're not competent to give that written consent. For statistical purposes, provided no person can be identified. for treatment, payment, healthcare operations, and research purposes on the same terms that those disclosures are allowed by HIPAA. So this is a place where this law aligns with HIPAA. And then we have a very major part of this law that has been really important during the COVID pandemic. This law allows release of information when release is necessary to protect the public health and the release is made in accordance with North Carolina's rules establishing communicable disease control measures. That "and" is really important because the determination of whether release is necessary to protect the public health isn't just an eyeball it and say, well, I think it is, or I think it's not. It is. It's a requirement that release be made in accordance with particular rules that we have establishing communicable disease control measures in North Carolina. And then there are a few other circumstances specified in the statute. Like I said, there's 11 particular subparagraphs, and I didn't write them all out here. But let's home in on that one about release that is necessary to protect the public health and made in accordance with the control measure rules. And I want to further home in on one particular communicable disease control measure rule that honestly, it did not come up a lot in my experience pre-COVID, but it's turned out to be pretty important in the pandemic. So I wanted to make sure you know about it. So let's take a look at the next slide. So this is a state administrative rule. It's a communicable disease control measure rule. The citation is there at the bottom of the slide. We have this rule that specifically allows health departments to disclose some communicable disease information to employers, to school principals or childcare operators, to jail administrators, and then to certain other people that you can see listed on the slide, when the disclosure is necessary to prevent transmission of the disease within the facility or establishment for which the person to whom the information is disclosed is responsible. So let's unpack that a little bit. First, let me make this point. This rule does not allow disclosure of information about HIV or sexually transmitted diseases, and that is probably one of the main reasons that, at least in my work, I haven't used this rule a whole lot in the past, but it does allow disclosure of information about COVID-19. And in making that disclosure, it allows the health department to disclose identifiable information, including the person's name and the fact that their diagnosis is COVID, but only when that disclosure of information is necessary to prevent transmission in the facility or establishment for which the employer or the principal, et cetera, is responsible. The rule also says that when the health department makes a disclosure of this nature, it must instruct the person to whom the information is given to keep it confidential. And then the employer or other person who receives the information must also help us with our communicable disease control work by requiring the person that they're notified about to comply with communicable disease control measures within the facility or establishment. And what does that mean? Well, it depends on the type of establishment, but for example, it could mean requiring them to stay home for the period that's prescribed by current public health guidance. Regarding the disclosure of individual names under this rule, I want to be very clear about what the rule allows and what it doesn't. It does allow the health department to disclose names to an employer, a principal, or another person named in the rule, but it does not mean that information that's identifiable can then be shared freely within the facility or the establishment. To the contrary, the rule specifically requires continued protection of the confidentiality of the infected person, and it requires the health department to instruct the employer, principal, et cetera, who gets the information in the importance of maintaining that confidentiality. We know that realistically, sometimes people are going to figure out who it is when you have an infection within a facility or establishment, but that does not change the health department's duty to keep the information confidential from others in the establishment and from the public. So I just wanted to make sure everyone was aware of this rule because it was one that, again, I had not used a whole lot earlier in my career, and I've been doing this for a while, but we have relied on it a good bit during the COVID pandemic to let health departments know when they're authorized to share information with certain kinds of employers and with schools, and also jails has been one that's come up a lot in my experience. Okay, so I'll invite you to, if you have any questions about this, feel free to put them in the chat box. We're going to come back to questions at the end, but for now, I'm going to leave this topic, the specific rule behind, and I'm going to switch gears. And I'm going to talk about a different kind of disclosure of information that's still about COVID, but with a different potential audience. So let's look at the next slide. Okay, you got there before I even asked, Lindsay, thank you. So this is about disclosures to the public. I know that many local health departments have received requests for disclosures of data to the public. And if you've called me to ask about disclosing data to the public, I have probably responded by asking you a question about your local hybrid entity designation. If HIPAA is not your main job, then when I ask that question, it probably sounds like I've missed the point, or I've talked to some county attorneys who have responded as if I'm speaking Martian or something. So let me give a little brief explainer about why I asked that question, in case it's not familiar to you. Hybrid entity is the just truly terrible jargon that HIPAA has given us to refer to a HIPAA covered entity that has both covered functions and non-covered functions, or in other words, the entity has some programs, services, activities, functions, etc., that have to comply with HIPAA, but then it also has some that don't. So, nasty jargon aside, hybrid entity is a really important concept for local governments because HIPAA doesn't apply to all of the individually identifiable health information that a local government or even a local health department may have. It applies only when that information is created, received, or maintained by a HIPAA-covered entity or a HIPAA-covered component of a hybrid entity. So, if and when an agency gets a request to disclose information to the public, one of the things that the agency is going to need to know in order to be able to determine whether they're allowed to make the disclosure that's been requested is whether the information is covered by HIPAA. And that question is answered in part by whether the information is created, received, or maintained by a HIPAA-covered entity. And that question is answered locally by a local hybrid entity designation. It's not something that anyone outside of the locality can answer for any given agency. You have to go into your HIPAA policies and find your own local hybrid entity designation. And because that local designation is what tells you which of your programs, activities, or functions are part of your HIPAA covered component, then that helps drive your response if you are asked for information. If it's coming from a HIPAA covered component, then you'll know that you need to make sure that if you're going to disclose the information, then you're going to comply with HIPAA as well as state law. The HIPAA hybrid entity designation rules allow some discretion on the local level, and this leads to an odd situation where HIPAA obligations are not identical for all public health agencies across the state of North Carolina. Local health departments do get to make some decisions about what they include in their covered components and what they don't. And you don't have unfettered discretion. If you have a clinical program that's billing Medicaid, that's got to be included. Anything that you're doing that includes the exchange of electronic information with a third-party payer, such as Medicaid or other insurance, that has got to be included in the hybrid entity designation. But other things, may or may not be. There's some local discretion that's involved in that. And so we do end up with this kind of strange situation where HIPAA coverage may vary from one department to the next. And certainly in the early days of the pandemic, I haven't heard this as much lately, but I talked to a lot of people who found this, especially reporters, who found this inconsistency a little bit mind-boggling. In fact, one of our state's newspapers actually wrote an editorial that expressed surprise, I'm going to put it that way. I think it might have even been skepticism that maybe I didn't know what I was talking about. They were quite surprised that federal law could be different from one county to the next. And I understand why that sounds like a very strange thing to say. But when it comes to HIPAA, it goes back to this hybrid entity stuff and the flexibility that's available to local departments there. Okay, so what local health departments disclose, what they're allowed to disclose, can also differ from what the state is allowed to disclose for this very same reason, because the North Carolina Department of Health and Human Services has its own hybrid entity designation, and that may allow it to disclose more granular information than can be disclosed from local records. And all of this is relevant when there is a question about disclosing county-specific data, and that's why I got into those weeds. Let's go to the next slide, and we'll go a little further into the weeds, and then we'll back out and talk about something totally different. Okay, so the question, the way it usually gets presented to me is, well, why does HIPAA affect the disclosure of data isn't it just numbers that we're talking about? And how could that possibly be relevant? And I understand that question. It makes a lot of sense. But the basic answer to it is that our laws, not just HIPAA, but also our state communicable disease confidentiality law, protect individually identifiable information. And we are concerned with whether an individual might be identifiable, even when the information we're disclosing is just numbers, because in some cases it might be, especially if the numbers are small or if the data are too granular. So HIPAA has a very prescriptive way of dealing with this, and that is by requiring information that is derived from protected health information to be de-identified before it can be disclosed. And under HIPAA, there are two ways and only two ways to de-identify data. And I'm going to address them in the opposite order than I have them on the slide. I apologize for that. But one is called the expert determination method. And frankly, this is the one that you're probably going to have to use if you are trying to de-identify protected health information at the county level, and I'll explain why in just a minute. So under the expert determination method, you can have someone who's been trained in statistical de-identification methods apply those methods and reach a determination about whether the information has been de-identified to a degree that, I'm quoting from the rule here, the risk is very small that the information could be used alone or in conjunction with other reasonably available information to identify an individual. So that's a pretty high standard. The expert who does this must document the methods that they use and the justification for their conclusion that the risk of an individual being identified is very small. In other words, they can't just eyeball it. They really have to do and document some methodology here. The other method for de-identifying protected health information before disclosing it to the public is called the safe harbor method. And this method requires the removal of 18 specific identifiers. And the 18 identifiers that have to be removed include what you would expect: names, birth dates, addresses, telephone numbers, similar unique identifiers. But it also includes all geographic subdivisions that are smaller than a state, including the name of the county. And I emphasize that part because that is exactly what makes it difficult for many local health departments to sufficiently de-identify county-specific data, because they want to present it by county, but if you're going to use the safe harbor method, then you got to strip the county most of the time. There's a little bit of an exception for large counties that pertains to zip codes, but for the vast majority of the state, you're going to have to take the county name off of the data. So because the safe harbor method requires the removal of that, it's really not usually a viable method to use if you want to disclose county-specific information. As a reminder, we also have the state communicable disease confidentiality law, which does say that information can't be it can be released for statistical purposes only if no person can be identified. Our state law does not have this kind of prescriptiveness around a de-identification method like HIPAA does, but the state's EPI section has a lot of experience with working with this and determining when small numbers should be suppressed to avoid the identification of individuals. And I think they've been advising some counties on this issue. Next slide, please. So once I say all that, you may be wondering how a county is ever able to disclose county-specific data in North Carolina or under HIPAA. And there are a couple of different ways that the disclosure of county-specific data can occur. One is that local health departments can disclose county-specific data that they get from the state. As I mentioned already, North Carolina DHHS is a hybrid entity, and its data component is not covered by HIPAA, so they don't have to follow the HIPAA de-identification procedures. What they have to do instead is what I just referred to about the state law, applying those internal protocols that they have for assuring that they're not creating a situation where individuals can be identified. And because of that, they don't always provide county-specific or highly granular data, especially when the numbers are small. But when the state has provided the data, you see here a screenshot of the state dashboard from the other day, information that's available there or information that they send back to you. If you request it, when the state has provided it, the local health departments may redisclose the data that they receive from the state. Another way that a local health department might be able to share county-specific data is if it's a hybrid entity. It is disclosing data from a non-covered component. In that case, it doesn't have to go through the HIPAA de-identification procedure, but it still needs to make sure that no individual can be de-identified under the state law if you're talking about reportable communicable disease information. And then finally, a local health department may also be able to de-identify county data using the expert determination method that I described rather than the safe harbor method. Okay, so that is all I've got about COVID and confidentiality today. Again, I'll invite you to ask your questions in the chat box if you have any, and we'll get back to them. But I am going to undertake a major shift in topics now and ask you now turn off the COVID-focused part of your brain if you can. I'm not sure if any of us can do that anymore, but turn that off for a minute and turn on the part of your brain that is concerned with mandatory reporting laws, those laws that sometimes require you to make reports to DSS or law enforcement. Today, I want to focus specifically on laws that require reports about children and adolescents under the age of 18, which is most of our mandatory reporting laws. But just to be clear, I'm not doing adult protective services today. I'm only talking about the kids. So this is a subject that I have addressed in this conference several times in the past, but there is an important update this year. You're probably aware of it, but I wanted to make sure. So let's go to the next slide. The update pertains to reports to law enforcement. I don't actually have any changes about mandatory reports to DSS this year, but I can't bring myself to talk about mandatory reporting without including a reminder that mandated reporting includes the duty to make a report to DSS when a person under the age of 18 is abused, neglected, or dependent. So I have put that reminder on this slide, but then that's all I'm going to say about it. I'm now going to focus on law enforcement and reports to law enforcement only. North Carolina now has 3 separate laws that mandate reports to law enforcement. There's a law that's been around forever, my whole career, which is forever as far as I'm concerned, that requires healthcare providers to report gunshot wounds and other specific injuries to law enforcement. So we have that. Then there's a somewhat newer law, last 10 years, called Cayley's Law that requires a report when a child under the age of 16 has disappeared and may be in danger. Now that law is directed primarily at parents who may be trying to cover up the death of their own child. It's named after a girl that happens to. Some of you may remember that case. I think it was Florida that came out of a few years back. But anyway, this law is primarily directed at parents of children under 16. Note the age here is 16. But it also requires anyone, potentially including healthcare providers, to make a report if you know that a child under the age of 16 has disappeared and may be in danger. And disappeared means that you have reason to believe that their parent or guardian does not know where they are and hasn't been in touch with them for over 24 hours. That does sometimes come up in health departments, so I do like to issue that little reminder as well. But what I want to focus on is this new law that we now have that requires reports of juvenile victims of certain crimes. So let's go to the next slide and take a quick look at that. On this slide, I have the requirement that is at the heart of the new law. The legislation created a new statute, GS 14-318.6, and this law states that a person age 18 or older who knows or should have reasonably known that a juvenile has been or is the victim of a violent offense, a sexual offense, or misdemeanor child abuse must make an immediate report to local law enforcement. The term juvenile is defined as a person under age 18 who is not married, emancipated, or serving in the U.S. Armed Forces. Next slide, please. I'm going to unpack that a little by looking at some specific questions, starting with the question of who must report under this new law. The general rule, those of you who know me know that when I say general rule, the next thing I'm going to say is exceptions in just a minute, but we'll start with the general rule, then we'll do the exceptions. The general rule is that this is a universal reporting law, which means that it applies to all adults. It says any person over the age of 18. So it applies to all adults, not just particular categories of professionals, but everyone age 18 or older who knows or should know that a juvenile has been or is the victim of a reportable offense. And there are just a few exceptions for some individuals with statutory privileges if they learn about a reportable offense in the context of a privileged communication. I want to emphasize that this exception does not apply to everyone with a statutory privilege, only some individuals. The legislature specifically accepted only the people that you see listed here on the slide. who have statutory privileges. Psychologists, psychological associates, their employees and agents, certified or licensed social workers who engaged in the private delivery of social work services, licensed mental health counselors, employees and agents of rape crisis centers and domestic violence programs, and there's an exception for the attorney-client privilege as well. But everyone else, including a lot of healthcare providers, must report. Specifically, I want to make this really clear, there is no exception to the mandatory reporting requirement for physicians, physician assistants, nurse practitioners, nurses, or those working under their direction. Even those are also people who have privileges. There's no exception to reporting in this law. Next slide, please. So what has to be reported? The law specifies that a report is required when a person knows or reasonably should know that a juvenile has been a victim of a violent offense, a sexual offense, or misdemeanor child abuse. And the law gets into a fair amount of detail about what each of those things is. So, not going to review them today. I have reviewed them in several webinars that exist already. And in fact, a couple of them are archived on my website, and it takes about an hour really to go through it in great detail. So what I've provided instead is how you can get to a narrative document, a handout, and also a 25 minute module, and also an hour or so webinar that I did for DPH last December on this. You can get to all of those online by following the instructions that you see on the screen here. You go to my website, which is ncphlaw.unc.edu, click on annual legislative updates, and then scroll down until you see the reference to this law. And you'll find all of those resources available for you there. I'm going to address only one category of report under this law because it's a frequently asked question, and that's on the next slide. So the new law requires a report to law enforcement when a juvenile is a victim of a sexually violent offense, and the law defines sexually violent offense as a violation of any of 29 criminal statutes, or in some cases, just specific provisions of those statutes. Like I said, it gets quite detailed. But one of the things that it's actually kind of clear about is reporting statutory rape and statutory sexual offenses. And this is a question that comes up a lot, has come up a lot over the course of my career. Do we report statutory rape to law enforcement when we find out about it? Before December 1st of last year, which is the date this new law took effect, the answer was actually almost always no. Sometimes that surprised people, but that was usually the answer. Now the answer is sometimes going to be yes, maybe it's often going to be yes. It depends on the age difference between the victim and the perpetrator. And so I have laid that out here because I don't think we can say this enough. A report of statutory rape or statutory sexual offense is not always required, but it is required when the victim is under age 13 and the perpetrator is 4 or more years older than the victim, or if the victim is ages 13 to 15 and the perpetrator is 6 or more years older than the victim. Those cases have to be reported to law enforcement. Whether you also report to DSS is a separate question, and the answer is not automatic. It has to be evaluated on a case-by-case basis with a focus on whether the minor is being abused or neglected by his parent, guardian, custodian, or other caretaker. Next slide, please. I wanted to end the discussion of the new law by acknowledging that it has raised some issues and concerns that I know about, and I want to extend an ongoing invitation to those of you watching to let me know if you have other concerns. This is still a relatively new law. It got passed really fast last year. It was enacted on November 7th. You were supposed to be complying with it by December 1st. When those of us who work with legislation first read it, we had a ton of questions that we didn't have answers to. There are still some questions we don't have answers to. And we also could see that this was a law that might have had a potential for unintended consequences. So I am interested in tracking concerns about this law. Here's my list so far. I think there's a risk that the initial response to this law may be over-reporting. I'm actually more concerned about over-reporting than under-reporting at this point, because I think the fear that you could face a misdemeanor charge if you fail to make the report might make people err on the side of reporting. Well, what's wrong with that? legally, what's wrong with it is a report that isn't required is likely a HIPAA breach and might violate other confidentiality laws too. And then there are also non-legal concerns because over-reporting could become a significant administrative burden for local government agencies, including law enforcement. I doubt they want to get flooded with a bunch of reports about offenses that they don't do something about. And then, of course, there's also a concern about the effect on public health. It's not a legal concern. It's strictly about protecting health in your communities. But we know from the literature that mandatory reporting laws always carry the risk of deterring some people from getting the care that they need. So that is a concern. Another concern is the effect on provider-patient relationships. Again, we know from the literature that mandatory reporting laws can damage those. Then there are some other ethical dilemmas that may come up. Patient confidentiality after information is provided to law enforcement. The law is very specific about protecting the identity of someone who reports, but it doesn't address protecting the identity of victims. Law enforcement does have some ability to keep that information confidential, but they appear to have discretion in the extent to which they do that in this case. And then there are some other concerns, but we're at the end of time, and so I'm not going to go through them. I want to go to the next slide to acknowledge that we have several references that were used by Kirsten, Virginia, and me in preparing the legal update. And if y'all want to hang in for a few more minutes, I'll certainly hang in and happy to take more questions. And while we're waiting for those, perhaps we can advance to the final slide, which has important information about how to get your professional development contact hours. Lindsay, do we have any questions we should respond to at this time?
I apologize. I will put the link for the evaluation in the chat box in just a second. It looks like we do have one question from Jerry Matson. How teen-friendly are the materials explaining this opt-out process for minors for some services, specifically the HIE opt-out for minors?
Yeah, so I'm happy to start a conversation about that. And if any of my colleagues would like to jump in, I invite that as well. So the HIEA, the Health Information Exchange Authority, developed, but there was an opportunity for a handful of stakeholders, including some of the local health departments that were involved in the pilot program and our office, to review and give some feedback on that form. And we did advocate for ensuring that the form was written at a level that was appropriate for teens, including the diversity of literacy levels. And also that the form, it really spoke to the things that might be chief concerns for folks who are exercising their right under the minor consent law. So today we talked about the legal components, the data sharing components, the capacity for consent. But for the minor who is exercising their right to consent under the minor consent law, big parts of their chief questions may be, who's going to be able to see my information? What's the scope and what are the limitations of my authority to exercise this ability to consent? And so we advocated for ensuring that the form also addressed those concerns that we thought teens might have. So the form does belong to HIEA. And what I presented this morning is what we think is going to be the final version of that form. But we were really appreciative of having the opportunity to provide that feedback to make sure that it was geared towards teens and suitable for that audience.
Thank you, Kirsten. I think that concludes all the questions that we had. I just wanted to remind everyone who is in attendance, the survey link is now in the chat box to, you have to complete that to get any continuing professional